Hello, I'm Hematologist Oncologist Dr. Tony Talebi, and today we're going to discuss the very important concept of palliative care and hospice care. Today I'm here with Dr. Stephen Bekanich, Associate Professor of Medicine at University of Miami and Director of Palliative Care. Thank you for being here.
Hello, good to be here.
Dr. Bekanich, what is palliative care?
That's a great question. Palliative medicine is a discipline that's relatively new. It's been recognized officially since 2006, even though people have been practicing it before that. It's a multidisciplinary specialty, meaning it takes advantages of the strengths of not only physicians, but nurses and social workers, the chaplaincy, pharmacists, and other therapists. And our goal is to either prevent or relieve suffering for patients and families who have significant illnesses. And so that "and families" section is a really important part of this, because we recognize that when patients have a serious illness, family members also get brought into this and can get sick themselves.
So oftentimes patients ask us, what is the difference between palliative care and hospice care?
This is something that I think even people in the field of healthcare struggle with, and it's probably going to take some time until there's more of a clear distinction. But palliative medicine, the key to palliative medicine compared to hospice care is that palliative medicine is given concurrently or at the same time as all life-prolonging or curative therapies. So if I apply that to cancer, what that means is patients should still be getting palliative care during chemotherapy, during radiation therapy, if they're going to get surgery for their malignancy. All those things can happen while you get palliative care. Hospice care is given more towards the end of life, and it's when often those other things are not desired or more importantly, not effective or appropriate.
I think that's a very good point, that patients can undergo chemotherapy and be under palliative care at the same time. Generally speaking, who requires palliative care? What type of patient?
Well, if we look at standards set through cancer care with the American Society of Clinical Oncology or the Commission on Cancer, what those governing bodies or professional organizations will say is that everybody that gets cancer should have access to palliative care. Now, not all of those patients will need palliative care, but the goal that we have is that patients and families get exposed to palliative care at the onset of their illness. Our role may be very minor. They may not see us very often. But as time goes on and either their illness advances or they have complications from their therapies, or this may turn into a chronic illness, that we'll see them more and more frequently. And so it's not saying, well, patients with lymphoma need to see us and patients with bladder cancer don't. It's that all patients should be aware that we're here to help. And how much we see them, we can tailor that on an individual basis.
I see. So what do you guys typically do to alleviate symptoms associated with cancer?
Okay. So one of our focus is symptom management. And when I talk about symptom management, medical education is typically very disease-focused. So when they come see our oncology faculty, we're oftentimes worried about the size of the tumor markers, other things that the tumors are going to impact or affect. What we do in palliative care is say, we're not looking at the disease because we trust you folks to get rid of that or help alleviate that. We're looking at what the patients are going through as a result of their disease. So in cancer patients, that oftentimes means pain, fatigue, sleep problems, nausea and vomiting, problems with your bowels, anxiety and depression. Those are all symptoms of an illness that you can have. And so we believe that those symptoms should be treated very aggressively. And there are evidence-based ways, and when I say evidence-based, meaning that we have lots of studies that look at how to approach this in a way that's going to bring about a satisfactory outcome. We have these evidence-based strategies to go about treating people. I'll use pain as an example. So oftentimes with cancer patients, they have multiple sources of pain. So over half of cancer patients have more than one site of pain. And pain is a very complex phenomenon. We know that there's not just one pain center in the brain, that if we look at patients who are experiencing pain and we study them in radiology and we look at what areas of the brain light up, we see multiple areas that are engaged when someone's uncomfortable. And so that means their mood is impacted, what they've gone through in their past plays a role in this, what types of receptors are involved within their body for this pain that they're experiencing. It's a very complex phenomenon. And oftentimes just throwing medications at someone is not the answer. And so we look at the whole person and take into consideration their values, their beliefs, their spirituality, what other underlying medical problems they have. And with this approach to symptom management, we say, okay, are the underlying diseases being controlled adequately? Oftentimes we look to our oncology colleagues or other specialists to make sure that that's being taken care of. Are there any treatments or medications that they're receiving that might be contributing to this? And then what are the different sources of their pain? Can we treat some of those things without medication? So can we treat them with exercise? Can we treat them with different therapies like physical therapy or massage therapy? Can we treat them with electrical stimulation? And so we try to pull in all these different modalities. And then we also, of course, use medications as well, and sometimes procedures. We have sort of a ladder for these symptoms where we start with things that are not going to be harmful, have minimal side effects, but still produce good results. And as time goes on, or pain or one of these other symptoms becomes more complicated, then we go up the ladder and pull in these other therapies that we can use.
How do you deal with shortness of breath associated with cancer?
Okay. Shortness of breath is a difficult symptom to have, and so there are lots of people that have described it as a more distressing experience than pain. So what we do is we start with the underlying disease, make sure that that's being treated maximally. Then we look at non-pharmacologic interventions, and with shortness of breath, it's things like psychological techniques, relaxation techniques, guided imagery. We get people what we call a breathlessness plan. So we actually go over what are your triggers, how to avoid the triggers. If the shortness of breath is triggered, how can you break the cycle? Because what people find with shortness of breath is that they enter into this vicious cycle with anxiety. The anxiety and shortness of breath are very much tied together. So how do you break that cycle? Again, without using medications. We do things like very simple things like have patients get a handheld fan at home so that they can hold it up to their face, and that's actually been shown to relieve shortness of breath. If all of those things are not working or the illness advances, then what happens next is we will start using medications like opioids. Opioids are is a family of medications that is oftentimes associated with pain, but it's also good for shortness of breath. It basically helps engage the receptors in the brain. When the lungs are saying, hey, I'm struggling or I'm having a hard time, it engages those receptors and helps ease the feeling of shortness of breath. And you can use much lower doses than people use for pain. So you can use medications like morphine or oxycodone to help them get relief. And using this sort of approach, patients have very good outcomes and remain safe. That's a big part of all of this because people are always worried about how are they going to tolerate things and the safety profile. And using this approach, you can achieve those things.
What about constipation? That can be very stressful for patients.
Right. A big part of constipation management is really focused education. So oftentimes, when you get sick like this, you don't pay attention to the basics, how much fluid you're taking in, making sure that you're getting exercise. Just those two things alone will have an enormous impact on your bowels. Also, when we're thinking about treating pain or some of these other symptoms, many of the medications we use can cause constipation. But as providers, we know that oftentimes it's overlooked to put people on bowel regimens. And so we have people on medications, and they don't need to be prescription medications. Oftentimes they can be natural remedies or things that you can get over the counter to keep the bowels moving during this time. The other thing that happens is, some of the therapies that we use or procedures cause diarrhea. And so people will get diarrhea, and then they'll stop taking their bowel medications, and then 7 days later they're really backed up and they're in the office and they're having problems with constipation and belly pain and so forth. And so it's that proactive educational approach to let patients really know what to expect, what's coming, what should you be prepared for, and also when to call for help.
What about nausea and vomiting associated with treatments or the cancer itself?
All right. So with chemotherapy, as you know, we oftentimes have anti-emetic or anti-nausea and vomiting regimens that we give people proactively with chemotherapy. That doesn't work for everybody. And then also there are other things with therapies that may cause nausea and vomiting. This is something that is also easily controlled as long as you're proactive about it. Nausea and vomiting is something that with good pharmacologic management, meaning medications that we can use to prevent this, winds up being something that's very treatable. And what we don't want patients to experience is to go home from the clinic and be throwing up for 3 days and then call us. Part of making sure that you have palliative care is that we're always available. So if you go home and you've had radiation and you're throwing up, you have a number to call, and we can try and help you immediately to keep you out of the emergency room or out of the hospital.
I see. What about the constant fatigue and difficulty sleeping that some patients go through?
Okay. Fatigue is one of the most challenging symptoms in all of cancer care. There are many things that are associated with it. And while there are medications that can be used that might be helpful, oftentimes fatigue is best addressed through a whole patient assessment where we look at, are you feeling anxious? Are you feeling depressed? What's happening at home? Are you getting enough exercise? Are you following good sleep hygiene? We know that cancer can be an overwhelming disease. So a lot of these basic life things wind up not being tended to when people go through cancer care, and just tending to those things will oftentimes help the fatigue.
I see. What about the concept of autonomy? Self-control is so important for cancer patients. How do you help them achieve some sort of control?
Okay. We act a lot like the education and communication team within the healthcare system. It is very difficult to uphold autonomy, and let's just define that for a second. Autonomy is something that every patient has a right to. It means that you're the captain of your own ship, that you have a right to direct your care. So you can refuse treatment, you have the right to be informed about different therapies that you're interested in. We want to put as much control in your court as a patient as possible. And so this is often done through good communication and education. When patients and families typically see providers, we know that the visits are relatively limited. You know, they may be 10, 15, or 20 minutes. We like to sit down with patients and families for extended periods of time to really hear their story, and bring them the educational piece so that they get true informed consent. What I mean by that is that they really understand what their choices are. They can get chemotherapy or not. They can go on dialysis or not. It's not our place to judge whether that's right or wrong. It's our place to make sure that they have all the information, that they have the tools to make good decisions. And that is one of the best ways to uphold someone's autonomy.
Very nice. How do you incorporate one's religious beliefs into palliative care?
Oftentimes, our spiritual life is not part of regular care. But we know that we have very good data or information that this is a significant issue for patients and families, oftentimes ignored by us as providers. And so we actually have a chaplain that's part of our team. Everybody that's trained in palliative medicine has some training in dealing with spiritual or existential distress. And so we encourage patients to talk about how that impacts their care or what's going on with their life in terms of spiritual distress. There are some things that we can do as physicians or nurse practitioners to help them along with that. But the take-home message for the patients is that if there are things that are beyond our expertise or our comfort level, we have a chaplain that's trained in all different religions that can help you through these troubled spiritual times.
I see. How do you deal with the depression and the emotional needs of the patient?
Depression is the co-pilot. I often will tell patients to cancer, to pain, to shortness of breath. Depression is always along there with you. There are really good evidence-based guidelines that have been reviewed by multiple professional societies that show that with both psychotherapy, so talking about how you're feeling and having therapy directed at how you're feeling, along with special types of medications for depression, can lead to improved symptoms and improved quality of life. And so we again here don't just take an approach where we throw more medications at someone. We get them therapy along with their medications that they take for depression or anxiety.
How do you address the family's emotional needs?
So I'm glad you asked that, because palliative care is really important for it's as important, I would argue, for families as well as for patients. So we know that if patients get cancer, that their partners or their caregivers or their loved ones, the cost of that caregiver's health care will go up. The number of diagnoses that partner or caregiver will increase. And so we don't have, in the American medical system, we don't have a very good structured way to take care of caregivers. Palliative care is trying to fill that gap. We ask physicians, oncologists, to send patients to us, even if the patient's doing well, but the family member is not. Because what we know is that caregivers and family members feel as though they don't have enough contact with us as providers, that they don't get enough information, that they feel as though they want a voice, a stronger voice in the care of the patient. What we need to recognize as a society is that once someone becomes ill and a family member chooses to be a caregiver, that becomes their life. And so them having an outlet in palliative care to express their feelings, to get out their frustrations, and to always have someone to go to for backup or continuity is really important. And I'll give an example of this. Oftentimes our patients are at home, they get seen in the emergency room for some sort of crisis, then they might go to the ICU, then they go to a med-surg floor, and then they go to a rehab facility or a nursing home, and then maybe back home, and it's this vicious cycle. Every time they're in a new environment, it's seeing a new team.
Right.
So they don't have a lot of continuity throughout all of this. And one of the things that our team does is we see patients in all of those different arenas or venues. We follow them throughout their course, and so we act as continuity for them. This actually relieves a fair amount of caregiver stress, because caregivers don't like to see new faces and to have to tell their story all over again everywhere they go. So seeing us and having that relief of familiar faces and people that are familiar with them, that they trust and are comfortable, is a great way to relieve that caregiver burden.
Well, thank you so much. What you do is so important. Thank you for watching. We hope this has been educational for you.
Thank you. It's been a pleasure.